Hello everyone, my name is Dr. Alexander Lawson and I am a foot and ankle surgeon in the Chicagoland area, and I'm a big Vikings fan. I had a request on Twitter from some fellow Vikings fans to do a video and break down the Kirk Cousins Achilles tendon rupture injury and discuss the surgery that was likely performed to fix his Achilles tendon. Before I get started, just a little intro about myself. Again, I'm Dr. Lawson. Went to college at Augustana College in the Quad Cities, the sister school of where C.J. Ham went to school. I went on to do my medical school training at Rosalind Franklin University of Medicine in Lake Bluff, Illinois, in the Chicagoland area. And then I did my 3-year residency training at Rush in Chicago. Now I work for a private foot and ankle center in the Chicagoland area known as Wild Foot and Ankle. So to start out this video, I wanted to first give a quick anatomy lesson of the Achilles tendon, which is the largest tendon in our body. If you look at the top of the image here, we see two muscle bellies coming together. You have the soleus muscle and the gastroc muscle, also called your calf muscle, that come together and form this Achilles tendon that is a long tendon and inserts into the top of the back of your heel, and it is the primary plantar flexor of your ankle. Now, there's several different types of Achilles tendon injuries, starting with something called tenosynovitis, which is the sheath surrounding the tendon that can become inflamed. Then you have actual tendonitis, which is the actual tendon becoming inflamed. And these are forms of acute inflammation. If you have acute inflammation that lasts several weeks, maybe even years, this is called tendinosis, which is a chronic inflammation where the actual collagen fibers will start to degenerate and get thicker over time, which can weaken the tendon and lead to a rupture. Now, in the case of most pro athletes, it's not degeneration of the tendon that leads to the rupture, more so just having the knee extended and then undergoing a lot of stress and force across the tendon as it lengthens to a point of failure and then it ruptures, likely what happened in both Aaron Rodgers and Kirk Cousins' scenario. Now, in terms of Achilles tendon tears, you can have partial tears where the tendon may partially tear across the tendon or even in length with the tendon. And then we have complete rupture of the tendon, which is what you see here in the image, where you have a distal segment of the tendon and a proximal segment of the tendon and an obvious gap in between there. And that is what Kirk Cousins and Aaron Rodgers suffered this season. This is an area of the tendon that you see in the picture that's called the mid-substance of the tendon, meaning that it's not at the insertion point to the heel bone, and it's distal to the point where the tendon meets the muscle belly, which is called the myotendinous junction. And this mid-substance area of the Achilles tendon has the worst blood supply and is usually the most likely area that the tendon does rupture. In terms of treatment for Achilles tendon rupture, we can use conservative therapy to treat the rupture, but this is most often reserved for older individuals who don't have high demand for athletic activities or use, as the Achilles tendon does heal in a lengthened state and cause weakness to the posterior muscle group. In terms of healthy young individuals, we often prefer and offer surgery, and almost always in the case of pro athletes, they will do surgery quickly. The way to treat this conservatively would be to cast someone in plantar flexion with the toes pointed more down towards the ground to bring that gap as close as possible and let the tendon heal over the course of 6 to 8 weeks and gradually improve the dorsiflexion of the patient's ankle to get them back to neutral eventually. In terms of surgery, the gold standard for repair of Achilles tendon has been end-to-end repair for as long as we've been doing surgery, but the techniques have changed over time. Now, what you see here in this image is a standard incision over the posterior aspect of your ankle to expose the torn Achilles tendon. You can see that we have a proximal and distal aspect of the Achilles tendon here, and this blue suture that you see sticking out of the tendon is called fiber wire. It's very strong and it's non-absorbable. The pattern that we use is something called a Krakow suture, which is very strong suture to grab both of these tendons, and then you'll have your assistant plantar flex that angle to bring the gap together. And once that gap is together, we'll tie multiple surgeon knots to tie that tendon back together. Now, some of the cons with this is, number one, you can see how large of an incision that this is going to take. Number two, the repair site is only as strong as your knots. So if the knots fail, the repair will fail. And number three is that we often see more complications with this procedure versus something called a minimal invasive or mini open procedure. The mini open procedure became common around 2012 to 2013 when this system called PARS, which stands for Percutaneous Achilles Repair System, became available via Arthrex. And this allowed us to make a much smaller incision horizontally, or transverse rather, at the level of the fracture gap. And then you use this thing called a jig to go in along the border of the tendon. And you use the jig to percutaneously place the fiber wire sutures through the skin into the tendon, and then you can repair the tendon through this small incision rather than making a very large incision. Now, this was still performing an end-to-end repair technique, so this is still not what Aaron Rodgers had performed, and I'll explain that in just a minute. But the goal of the PAR system was to be able to repair the tendon end-to-end with a much smaller incision that would reduce operation time and reduce complications, which this procedure was able to do effectively. Later in the 2010s, around the time of 2017 or so, we were then able to adapt this procedure to instead repair the gap end to end, to modify it slightly by avoiding knots at the gap site of the Achilles tendon, and instead anchor the fiber wire into the heel bone or the calcaneus, which you can see at the bottom of this picture here with these two anchors, both medial and lateral, in the heel bone. This is exactly what Aaron Rodgers had performed, and it's very similar to an end-to-end repair, except for there are some pros to this, such as less surgery time, less inflammation at the rupture site, and it's also a slightly stronger repair because you're not relying on the knot strength at the gap site of the Achilles tendon, but rather these bone anchors in the heel bone are going to keep that tendon gap nice and reduced at the rupture site. So the difference with this procedure is, rather than doing an end-to-end repair, we're still passing that suture percutaneously with a transverse incision, and then you're feeding that suture through two distal stab incisions by the insertion of the heel bone. And what you're seeing in this picture here is that there's a drill that we do into the medial and lateral aspect of the heel bone, followed by the bone anchor that we grab that suture, that fiber wire strong suture, and then we tension the heel where we want it to bring that gap of the Achilles tendon back to nice anatomic alignment. And then we put that bone anchor into the heel bone, which is basically like a screw that goes into your heel bone. It's going to keep that tension across the Achilles tendon exactly where we want it. Now, this is very important in regards to tension and post-op re-rupture rates. So we see that with this technique, with any technique with surgery, we do have a lower re-rupture rate than treating conservatively, which is a big reason why athletes will have the surgery performed, but also the return to sport is much quicker. The advancements that we've made in the medical community to repair the Achilles tendon minimally invasive and cut down on operation time and complications still doesn't speed up the recovery of this procedure, however. We note here in this study, which included 95 NFL players with a mean age of 28 years old, that it did take 339 days. So we're talking 9 months to a year, plus or minus 84 days, to get back to return to sport. Now, being a quarterback, we can probably cut that down a little bit. I'm still looking at least 6 to 7 months for return to sport, and I'm leaning closer to 7 or 8 months, to be honest. Knowing this information, I find it highly unlikely, less than a 1% chance, that Aaron Rodgers would be able to return to the playoffs. I just don't buy it. I think a lot of what you've heard about the procedure and the advancements of the procedure and the return to sport from this procedure is just propaganda, to be honest with you. Now, people might be asking, well, how can Aaron Rodgers get on that football field and throw a football? You can walk on a repaired Achilles tendon 6 to 8 weeks after surgery without a boot. It only takes 6 to 8 weeks for that tendon to form like a scar ball, if you will, to become strong. It takes much longer for that scar ball to remodel and become much stronger to the point where you can return to sport, and that's why it takes 9 months or so to return to sport. In addition to that, you're talking about the weakness and recovery from that gastroc to gain that explosiveness back after the injury. That's why it takes so long. So in my opinion, Kirk Cousins is likely not going to pass a physical until probably June or July of next year, just before training camp, but hopefully, and I wish him a speedy recovery, and I wish him the best going forward.